Okay,
Yeah.
so yeah, thanks for joining us tonight with the Celtic SMR webinar. So a couple of weeks ago we looked at the anterior and posterior knee. We're going to look at the medial and lateral. It's not going to be a very long webinar, this one, because there's only a few things that we can look at. But we'll start off with the medial knee. Okay, so you can see that. So there's a few structures to look at the medial side. We've got the obviously the joint space. You've got the meniscus in the joint space, which isn't the best. Ultrasound is not the best to examine the meniscus, obviously, because we can't see it all. But you can see these sort of medial and lateral components of the meniscus. So if you do see a tear, which we'll have a look on the screen shortly, you can call it. But don't if you don't see one, you can't obviously rule it out. And then we'll have a look at the medial collateral ligament here. Now there's a couple of components. There's obviously a superficial component here, which you can see, and then underneath this there's a more of a femoral meniscal component and a tibial meniscal component. Okay, so there's two components there. And then what we'll do is we'll come down to the pes anserine, which is obviously made up of the sartorius, gracilis, and semitendinosus. I'll show you where you can look at those. We'll then move over to the lateral side, okay, and look at obviously the lateral joint space. We'll look at the lateral collateral ligament. We'll look at Gerdy's tubercle, which is here, and that goes off onto the ITB, and where you can get sort of the ITB syndrome around here. And then obviously we'll just show you where biceps femoris inserts as well, to not get too confused with those. And I've got a little thing to show you how you can sort of remember these, but we'll do that a bit later. So back to the medial, that's what we'll start with. So basically just plonk your probe straight on to the joint space, look for the joint space, and then you can pick up the ligament tip quite easily. It's quite a broad ligament, so you've got to look all the way through it. So we'll jump to the scanning now.
Can I just say something about that, Adrian? I did a little experiment a few years ago, and we were testing, playing around with younger physios and trying to see how good they were at identifying the joint line and margin. So we asked them to draw with a little pen where they thought the joint margin was, and then we used ultrasound to show them where it actually was.
Okay.
And interestingly, not many got it right. People thought it was much lower than it actually was.
Yeah, exactly. Well, I mean, you can.
So there's so many uses. It's not just for diagnostic stuff, you know. It's landmarking.
Yeah, exactly. So if I just open that up a little bit, so you can see the joint space here. If I scan down, you can see it's still joint space. You don't get to see very much. And scan up. That's so I've sort of scanned all the way through the joint space there. So this here is my arrow on. So this is the medial meniscus here, and you can see you can only see this sort of component of it, and you're looking for a nice homogeneous, bright appearance here. If you do get a little tear, it'll be like a hyperechoic defect. You might get a little cyst come out as a meniscal cyst. You'll see a little pocket of fluid pop out there. And look at see if there's any meniscal cysts. Look at the bony contour, nice smooth bony contour here, and look either side for sort of arthritic osteophytes and things like that.
In a healthy knee, what would you expect the joint to measure? Space?
Oh gosh, you're asking me things that I don't tend to measure the joint space.
What are you looking for? Erosions?
Yeah, erosions. I mean, I can compare it if I feel like it's particularly. I mean, you'll see that it looks narrowed and reduced cartilage. I mean, there's a bit of cartilage here, but I just tend to eyeball it.
What do you think there's about 7-8 mil there?
Yeah, there may be some figures in the literature that what it should be, but
I've measured it in people with mild to moderate degenerative changes, and I think the more advanced changes, they're down to about 2 to 3 millimeters, and sometimes even you can see bone on bone and very little cartilage in the middle.
So you've got sort of 45.5 there, depending on where you measure it. So here, let's have a look at, so this here, this broad component here is the superficial component of the medial collateral ligament, okay? And it goes across the top, and the superficial one will obviously carry on down way past, probably approximately about 7 centimeters past the actual joint space. So it's quite a long ligament component. The deeper component, so there's the femoral meniscal component across here, and the tibial meniscal component, it's about 1 centimeter past the joint space. Okay. And then you can, if you tend to get most disruptions around here, and it'll be very dark. You might see a hyperechoic defect, a bit of fluid maybe. So you can assess for that. Yeah, so let's follow this other component down now. So if you follow that component down, see it's going all the way past here. It crosses over. This is the genicular artery here, and there's obviously a nerve in here. Some of it's so small we're not going to see it. So you do get a bursa down here, which is where the pes anserine appears. So you get this is the medial collateral ligament that inserts down here, and then you've got the pes anserine, so you've got the sartorius, gracilis, and semitendinosus here. And then you'll have obviously a pes anserine bursa here, but you don't see it, there's nothing there, but you'd see a black fluid area here. And then obviously you can turn.
Here's my patella.
Long section. Yeah. Long section on that, and follow each one of those back into the muscle, into the muscle belly. Now we had okay, so there's 3 of these. Now, when you get right to the insertion, you'll see probably only 2 because the gracilis and tendinosus sort of merge into one. So you'll probably only see 2. There's one here, just a little bit dark. You have to make it dark to see them. Another one there. And then you just angle long section, and you can follow those back. And they look dark because of just my angle and the way it's positioned. But you can follow them, you can see that they're intact. Okay, and obviously if you've got, you can get, bulging of the meniscus that pushes this out, and you'll be able to document that as like a bit of meniscal protrusion here, and then that will push this component of the medial collateral up and out, so you can pick up that as well. To say this is quite a broad component to the medial collateral ligament, so assess all this here, and obviously you can go across in transverse section as well, but it's quite difficult to do that. If you come down, just while we're on the medial side, if you come down to the joint space, go slightly down until you see this dip. This is actually where the semimembranosus is inserts. So you can see the semimembranosus here nicely. Oh, no, there's your bit of.
Oh yes.
So I don't really can see this back here. Don't worry. Talking about
no, not at all. You're welcome to my lumps and bumps.
Okay, just back here, you can see in Abid's behind his knee, behind his medial aspect of the knee, is this sort of cystic structure. It's not actually a Baker cyst, but it's not in the typical location for a Baker cyst, even though it is on the medial side. But it seems to be between, we were trying to work this out earlier, the sartorius muscle, I think, and the semimembranosus tendon. So this is a cyst here. You can see the enhancement here behind it. And what I usually do is I usually put the Doppler on as well, just to make sure that there's no sort of internal flow within that sort of artifact there that you're seeing. So you have to be careful. Let me turn this down. When you're moving, because if you move, obviously you'll create a lot of artifacts.
But we're not sure what that is, are we?
No, well, it's a cyst of some sort, but it's.
We were trying to identify the actual structure that it was maybe attached to.
So it seems to be just adjacent to the. This is my finger. You can see the semimembranosus tendon and the sartorius muscle belly. So yeah.
Any suggestions on what you might call that?
I was going to say.
Greatly welcome.
Yeah, I'd call it I'd call it. It looks like a pretty much a simple cyst, but it's the location really. So I'd probably refer that to MRI and get them to sort of find out exactly where that is and characterise it a bit more. But you have to be really careful with lumps and bumps. I think we're going to talk about lumps and bumps at some point, but lumps and bumps are really careful. You have to be really careful because they do cross over, and things can look benign and they'll be malignant, and things can look malignant and they'll be benign. So you just have to follow a few schools of thought really. Just look at the outline. Is it a smooth outline? What's the contents like? Is it simple contents or is it complex contents? Is there any shadowing? Is there any enhancements? Is it deep? It is deep on this occasion. Is there any vascular flow? And things like that. And all those things can help you characterise what it is. It won't tell you exactly what it is, because obviously only a biopsy could do that, but it can put you in the right direction and obviously go on to further imaging or further investigation. So do be careful with lumps and bumps. Okay, I think that's pretty much the medial. I say it's pretty basic area. For the lateral, I'm just going to just bend you up again, Abid, there, if you can mind. Yeah, cool. So a few more things on this aspect. Let's bring the focus up a bit. Take that red dot up there. Bring the depth down a bit. Get a bit more real estate. So there's your bog standard lateral knee picture. You've got that dip here, which is where the popliteus tendon sits in there. And if I could probably just angle that a little bit, and you can see that inserting in there, and it runs off down there. So you've got the popliteus tendon there, and again look for bony irregularities, anything like that, osteophytes. Again, look at the meniscus, which is here. There's an artery there, look, you see that pumping away. See that little artery there. Don't mistake that for a cyst or a tear. Just look at it, be still, and you'll see it pulse. And then you can be sure that that's an artery. Okay. So there's popliteus. So this here, a lot of people, when they first start out, pick up this, say, oh, there we go, there's the lateral collateral ligament. It's not. It's this is good. It's tubercle here, and this is the ITB. And you can follow the ITB up and over. I'll get you to just straighten out a little bit out of it. Sorry. Yeah, so this is the ITB. So this is where you get all the ITB syndrome and stuff like that, be thickened, and you can do dynamic manoeuvres of the leg to see if it's impinging and rubbing here. This is where you look at the ITB, and then obviously the ITB goes up the thigh, and to carry on there. So this is a bit of lateralis here. Okay.
Yeah, I suppose you could show that all the way up to the trochanter if you like.
Yeah, and then
that'd be interesting.
Yeah, you can do that, but it goes very thin, so you're literally just following a thin line up. You need a lot of gel. So it's very thin, but you're basically following this line all the way up, and you can follow it right to the lateral lateral hip, greater trochanter. I mean, we'll probably cover the hip in another session, and then it splits into tensor fasciae lata and gluteus maximus and things like that. So so you're going to follow this up. That's about as far as I'm going to get, I think. And then if I go transverse, we're into greater trochanter, not quite. Yeah, it's a little bit deeper than that. I need to bring the focus down. There we go. So overlying here. But anyway, we'll cover that more if we do a lateral hip one. Okay, so where were we? Right. Come down a little bit. Get the focus up. Constantly adjusting your settings all the time gives you the best image. So when you want to find the lateral clitoris, it's best to just, instead of trying to find it, just palpate the fibula, put your probe right on the fibula, then you know you're in roughly the right place. And it's going to be, I don't know whether you can see that little, hang on a minute, little black structure. This here, and because of the way it is, the contour is quite undulating. There, that's essentially the lateral collateral ligament, and going up to there. Now you can put this under a little bit of stress, which makes it a little bit better. I'm going to freeze it there so I can show you. And that is then coming across here, and see how much that's stretched out now. So you can interrogate it a bit more, and it's nice and bright. Going across there. And that's the lateral there. Now for the biceps femoris, I'll take you back this way. So for the lateral, obviously you're going to be on the fibula, but pointing back towards the femur here. For the biceps femoris, you're going to angle back because that's where the muscle goes posteriorly. So like on the Z, yeah, we're angling back that way. So that's the collateral, that's the ITB, that's the biceps femoris. Okay, and this is it here. I probably need a decrease of depth, it's a bit blurry. And that's it going off back here, and you know you're there because you've got this short head of biceps here coming in. Okay, and then let's make sure I'm turning this in the right way. Then as you go up, this is still short head. No, I've got that wrong way around, sorry. So the probe, you've got to make sure you have the probe turned the right way, otherwise everything goes backwards for you. So it's like there's short head. And then going into long head here. Back into short head. Okay, and then you're almost back into hamstrings and things like that. That's a different exam again. So you follow these, all these little intramuscular septa here. They all coalesce back to the fibular head. Fibular head down here. Sorry. There. So yeah, you see this, I'm missing a bit of contact here. That's why I'm getting a big shadow here. So I need some gel. Slightly better, and you can decrease your frequency if you want to, just to give you a bit more penetration there. And then back onto the fibular head. There. We were talking about the perineal nerve as well, weren't we?
Yes, perineal nerves quite nice to identify on ultrasound. We're talking about not many people would refer to look at that. Probably more for nerve conduction studies, but it's quite interesting to see it.
So this is the nerve here. And follow it. There's the fibular head. And it gets really difficult here as you go in the fibula, so I tend to go long section here. And follow it past the fibular head.
Yeah, we were thinking about trying to find, bringing a couple of drop foot patients and having a little look at the perineal nerve, see what the difference is.
And you can follow the nerve down.
Because it's quite nice and big nerve to see around the fib head.
Just here. Yeah, see the little honeycomb appearance, little black dots. Yeah, I can bring my focus down. And that just helps follow the nerve down. And down into mid calf now. And that's pretty much what I do for a medial lateral knee. Any more questions coming in there, Steve?
I have got a couple of...
Just to overview then, so typical medial lateral knee exam. Probe placement as close to the... Well, actually, I'd normally place my probe on the patella, actually, and then...
Oh, do you?
Yeah, just to give myself a, that bony landmark.
Yeah, so you got patella tendon,
yes.
and then you just roll off.
Just roll off, and then should be,
Equally good.
It just because, like I said, sometimes you're in the deep blue sea, just moving around if you're not quite.
Yeah.
So first of all, look at the joint line.
Look at the joint line.
Assess that.
Meniscus, things around the joints.
Effusions. Do you tend to see effusion in the medial or lateral joint margins, or? You
can do. You tend to. Usually, you get if you look at the anterior knee, you'll get an effusion.
Sure, suprapatellar patch.
Yeah, which will extend medial and laterally. So you'll see a fusion over on the medial side and also on the lateral side.
You won't see any in the actual joint margin itself.
Well, you could do. You could see effusion pop out here.
Yeah.
You could see a cyst.
Hematoma.
Hematoma.
And did you get many traumatic knee scan requests?
I don't. Do you know what? I think most of them go for MRI, to be honest, because it's such a.
Yes.
Because they usually, if they've got a big trauma to the knee, there's more than likely going to be some internal derangement. So they'd rather just get a knee and get it all done in one shot. So you don't see many traumatic knees coming in, which is why I don't tend to do any stress manoeuvres on the ligaments unless they specifically ask for them.
Yeah, but it's also great for injection placement.
Yeah.
Yeah, so you know exactly where you are in the joint margin. You can see I'm just rolling my finger, and you can see we're just about over the joint margin there, from a little bit further down.
Yeah.
Mark it. So I can just use that to locate the joint margin. That's what we do, is just make a little fingernail mark there.
Yeah.
And then obviously sterilise and do whatever. So you don't have to do it as a guided procedure as such. I call it ultrasound marked procedure.
Oh, yeah.
Again, effusions are just fantastic to deal with when you have ultrasound in hand, because you'll just put your needle straight into that effusion. You can tell if you've got it all or not. One
thing you will notice is if you have got a lot of fluid around the knee, it makes visualization of all your structures really nice, because fluid's a really good thing with ultrasound. It allows you to look at things in a lot more detail. So if you do have a lot of fluid around the knee, it does make your visualization of the structures a lot easier.
Yeah, I think I tend to use it to look at the medial lateral collaterals and the joint margin, and probably the patellar tendon for the most, and for Baker's cysts, of course. It's just invaluable for that.
Exactly.
I don't often look at the semi-run tendons, although maybe I should make more of a point of looking at them.
I don't tend to routinely look at them, but if they've got pain somewhere at the back and I can't find a Baker's cyst and I can't find a cause for it,
sure.
I just have a look at a bit more detail around, and more often I picked up once a small little tear in the semimembranosus insertion, and I just a little bit of pressure on the probe, and then that's it.
Yeah.
And it just picks it out. So
and that's the wonderful thing. Of course, we're looking at things dynamically, so it's very nice to stress and test and put and poke.
Yeah.
Whilst trying.
So just looking at your cyst here, Abid, I might actually upgrade it to a.
Oh no!
I might actually upgrade it to a bit of a complex cyst, because I don't know if you can see.
Let's have a look. Yeah, there's a bit of.
There's maybe a little bit of septation within the cyst here. You see those little white lines?
Yes. Yeah. Yeah.
So I probably wouldn't call this a simple cyst. I just call it a complex with a small septation in.
Yeah.
I don't for 1 minute think it's anything nasty, just because of the way the other things it looks. But as I say, you can never always be sure, and I'd probably just want an MRI correlation on that if it was me.
Fantastic. Thanks for giving me a sleepless night there.
I always thought you were complex there. Actually, on the Baker's, came in a bit earlier, actually. I'm not sure if it's a question or suggestion. Could you identify the relevant structure of the Baker's cyst by labelling in transverse section?
Yeah, I mean, I need to turn you over.
Okay, bear with, guys. Let me just get in position for you.
So the Baker's cyst is characterised as a, like a medial gastroc semimembranosus bursa. So the only way you can call it is if you see it between those two components. So the first thing I do is I find this is what I call the sort of cherry on top of the semimembranosus. Okay, and I just follow the tendon down. Yeah, I haven't quite got on the other side here, so hold on, let's get back. follow it down until you see this component. So this is the medial head of gastroc. And then the now he hasn't got a Baker's cyst, so it's going to be really difficult to pick up your landmarks here. But when there's a Baker's cyst, you'll see this here opens up into like a speech bubble. So you can almost see the little C, inverted sort of C appearance here. And that fills with fluid, and that sort of denotes the medial head of gastroc. And then you'll get the semimembranosus tendon about here, and it just defines the two. It goes right through the two, and that's how you call it. That's when you know it's a Baker's cyst. So you must always see this speech bubble appearance in the neck going down here. If you don't see that, you can't call it a Baker's cyst. And obviously he hasn't got one, but he's got the other cyst. Where was it?
The other knee.
That was the other knee, yeah. There we go.
Do you want to see that from the posterior aspect?
Yeah, let's yeah.
I'll go that way.
So there's the cyst there. Oops, put you there again. So there's the cyst there. Here's the tendinosis, membranosus. If you follow it down, you see way past the cyst now. And there's the medial head of gastroc, and there's that C position here. You can see that's where you find the Baker's cyst. So it's a bit more superior and medial, the cyst, is where you find the Baker's cyst. Yeah, and you can see that little septation there going through. So, I mean, I've got one on my knee, to be honest, but it's on the lateral aspect, and it looks a lot more complex than this, so I wouldn't be worried at all, Abby, but...
Thanks for reassuring. It's making me feel worse, Steve. Keep going on about it now.
Okay, now then, we've got a question and a couple of requests here, so don't get comfortable. Don't get comfortable just yet. So one question from Elaine: how far would the meniscus before you diagnose acute injury, or is the presence of inflammation the determining factor?
So how far the meniscus?
How far would the meniscus protrude before you diagnose acute injury?
Protrude.
I think she's asking if there'd be some vascularity or any other features around it.
I would say it's protruding. If I look here, you see how it
does actually look like it's just dislodged and slightly out of place when you see it.
Yeah,
protruding.
you see the collateral ligaments going. The medial ligaments going. Medial collateral ligament is going straight across, and there's no bulging of that ligament. So if the meniscus bulges, that ligament will bulge.
Yeah.
So if I see that contour of that ligament bulge, then I'll say that it's protruding.
Yes.
And that's as simple as I call it.
And do you want to put colour flow Doppler onto there?
Yeah, you can do.
What are you looking for then? If you put, I mean,
well, just
would you expect to see blood flow to the meniscus? I don't think.
If it was really hypervascular, I'd probably say there's some sort of synovitis going on.
Yes. Yeah. And you do see that fairly commonly
Yeah.
A lot of rheumatoid things.
Yeah.
You know, a bit like a Christmas tree in there.
Yeah, they do. Certainly, if you've got, but you have to just be aware of your settings. You do need to set your settings right when you're calling Doppler things. So,
see many from rheumatology? I mean, hands and feet.
I don't, to be honest. Rheumatology, they just tend to send me hands, wrists.
Yeah.
They don't see many requests for knees through rheumatology.
Yeah.
Obviously, you can, but
I suppose they send their aspirates and other investigations. MRI seems to be the standard, doesn't it?
I think really when they come to me, they're trying to pick up rheumatology appearances for the first time. subclinical synovitis, and that tends to present in the hands first. So that's probably why I just get sort of hands and wrists into me, and then once they know it's there, then they can look at other things with different modalities. I think did that answer the question there, Steve?
I think it did. I'm sure Elaine will come back to me if not. Please do, Elaine, if it doesn't. Thank you. And okay, a couple of requests. Could you differentiate the acute ligament and the transverse popliteal ligament?
Oh God, transverse popliteal ligament. I wouldn't look. I don't routinely look at the transverse popliteal ligament. And what was the other one?
A tough crowd tonight for you.
God dear. Transverse popliteal. I didn't even know where to look for that.
Elaine says that's very helpful, so thank you.
Oh, good.
On that previous question, but not on this one. You're not off.
Not on this one.
No, if you can help us out anatomically, we're not quite sure where that lives.
No, I mean, it sounds like that sort of thing would go to MRI.
Okay.
What was the other one?
Could you demonstrate the medial lateral coronary ligament?
No, see, these sort of things are going to go to MRI.
MRI. Okay.
We can see the superficial things, the deeper things are. It's just hard to pick up with the grayscale because we had a little play around earlier as well, just to see how much detail we can get. And again, it's depending on lots of factors as to how deep and how clear you can get. And obviously, there's a reason the MRI has become the standard almost for a lot of these smaller ligamentous injuries in the knee.
Yeah.
When in plica and things like that, it's
yeah. I mean,
real tough.
You only tend to see that with this fluid surrounding it.
But it's very useful in your clinic. You can just see and rule out a lot of stuff. Small ligament injuries. I suppose so from a sporting point of view, perhaps more relevant. But again, with sports guys, you probably want to go for MRIs because there's usually more than one thing going on there.
Yeah. So sorry, whoever asked that. That doesn't routinely come to ultrasound. Looking at those.
Tricky. Theoretically, I suppose, with a bit of time. A bit of a play around.
Oh yeah.
The right kit.
Okay.
Okay. I'll just encourage anyone else if they've got any other questions. Quite a few requests coming there, so if I've missed anything, guys, flag it up to me now. But at the moment, I think we've covered everything that people have asked us to. Thank you, guys. Oh, one message coming in. For those going forward with MSK ultrasound courses at postgrad, please could you recommend places? Is that something you can cover tonight, or should we keep that back?
Well, there's a few places. I mean, it's a long time since I've looked at that area of it, but I know there's the Bournemouth course, isn't there? The AECC.
That can lead you on to a diploma, postgraduate certificate, or MSc as well. Yeah. Birmingham.
I did mine in Cumbria. That was good. But I think there's lots more actually popping up now. In fact, even the Brunel with the ultrasound site, they've got a course running now with Brunel University. The difficulty is that you'll be faced with is getting mentorship. So finding a mentor and having that throughput of patients to scan. That's where you're going to find the stumbling block, unless you're doing it through a hospital. So just be aware that is going to be a stumbling block, but you need to get as much hands-on as you can while you're learning. Those are the main ones I think that do that.
There's a lot of good resources out there, isn't there? I'm going to give Abid a plug because I know the institute. You've got a good course going on the lower limb, of course. Abid, appreciate that. It's just
of course you got
Yeah, we deliver most of the modules online by e-learning, and then you do a MCQ online to pass the theory elements, which then will lead you on to 2 days of pure practical training with Adrian and myself. We're just hands-on, 2 full days of it, lots and lots of scanning time, and then we offer mentorship at the end of that as well.
Great. Yeah, I mean, I'm really excited. In a few weeks' time, about the 8th or 9th of September, it still seems to be going ahead. MSK US, Peter Restaghini, I'm sure most of you know, great guy, so knowledgeable. The Homerton Hospital, they've got courses. Our scanners are supporting that week, so I'm really.
Yeah,
I think he's professor now, isn't he? Professor.
There's some really good resources out there. But thank you, everybody. Some nice comments coming in. The general message we've just got across there is, we'll keep putting these on. We really appreciate the enthusiasm coming from you guys coming in and joining us. We'll keep improving where we can, adding in where we can. Got some exciting stuff coming up. But otherwise, thanks again, Adrian and Abid. Home safe to you too. And thank you, everybody else.